We will now spend some time on the actual treatment of the acute uncomplicated myocardial infarction. When the patient arrives in the emergency room after the myocardial infarction has been documented, it is imperative to open a line to the vascular system, and an intravenous medication line should be opened utilizing probably 5% dextrose in water or 5% dextrose in saline. Lactated ringers may be utilized, but the fear of lactic acidosis is present, but probably not to be concerned of at the emergency situation. Oxygen is needed, and usually at approximately 7 liters, unless you are dealing with a patient with chronic obstructive lung disease. It is imperative that the pain be abated. This pain has been classically abated utilizing intravenous morphine sulfate. There are certain problems which can occur. Among these are hypotension, nausea and vomiting, depressed respiration, and even seizing of the chest, stopping respiration. Some authorities feel that the patient should be snowed with the morphine, but some authorities feel that possibly Demerol and Phenergan or Demerol and Atarax may be more benefit to the patient in preventing the complications of morphine. In today's medicine, and keeping with the standards of the community, a patient with acute myocardial infarction should be placed in an intensive care unit or at least on a cardiac monitor where he may be monitored by the nursing and paramedical personnel. A word about anticoagulants. As you are aware, if you were to read 12 articles on anticoagulants, 6 would be in favor, 6 would be against. There is probably very little evidence that anticoagulation prevents recurrence of acute myocardial infarction by preventing coronary thrombosis. Anticoagulants do, however, markedly lower the incidence of venous thrombosis, pulmonary emboli, and peripheral emboli. We must be careful with hemorrhage in the patient on anticoagulants. The anticoagulants are obviously contraindicated in patients with liver disease, azotemia, and severe hypertension. Let us spend a few moments now talking about the complications of acute myocardial infarction. As we mentioned, outside of the hospital, 1/2 to 2/3 of the patients die, usually a dysrhythmic death. Usually this is ventricular fibrillation. It can occur within 4 hours of the onset of pain. It can occur immediately after the onset of pain. The patients who are high risk may be instructed in the self-administration of drugs to prevent the occurrence of the acute myocardial infarction complication, that of arrhythmia. Lidocaine, 250 to 300 milligrams injected intramuscularly, is usually effective for at least the next hour. This may be given in a dose of 3 cc's in each hip of the concentration of 40 milligrams per cc of lidocaine, which is available and should be kept in the physician's office, and as mentioned, the high-risk patients. We mentioned atropine before. This is not so convincing. There is one theory that holds that bradyarrhythmias may predispose to ventricular fibrillation, but there is another equally erudite school who feels that the bradyarrhythmias may be a protective mechanism during the acute myocardial infarction. The same may be true of slow ventricular tachycardia. Therefore, the use of atropine is still a matter of controversy. We may, however, instruct our patients in the use of atropine to be given 1/150th grains should the bradycardia occur. We next talk about some of the further, more serious complications of acute myocardial infarction, and these include the various tachyarrhythmias and the premature ventricular contractions. We treat premature ventricular contractions, especially in the acute myocardial infarction patient, if, number 1, they are greater than 6 per minute, number 2, if they are coupled, number 3, if ventricular tachycardia is present, and don't forget that by definition, 3 PVCs in a row represent ventricular tachycardia. We also treat PVCs that interrupt the T wave and multifocal in premature ventricular contractions. Don't forget that PVCs interrupting the T wave are very prone to cause ventricular fibrillation. These are treated by the use of a lidocaine bolus, either in a dose of 50 milligrams to 100 milligrams intravenously, and to be repeated within 5 to 10 minutes should the PVCs not abate. Should this be ineffective, we then many times will go to the xylocaine drip, and this is given at a dosage of from 2 to 8 grams in 500 cc's of 5% dextrose in water. we attempt to deliver 4 milligrams per minute utilizing a microdrip, and we have been in the habit of using the IVAC, the IVAC, in order to accurately keep track of the microdrips. When we place a patient on a lidocaine drip, it is important to place the patient also on dilantin, 100 milligrams every 8 hours, either orally or intramuscularly, to prevent the sequelae of lidocaine administration, which can be seizure activity. One of the toughest things that I have is to convince these young whippersnapper internal residents to remember about the drug Pronestil. This is a very fine drug and is probably the drug of choice to prevent the long-term occurrence of premature ventricular contraction. This is administered with a loading dose of 750 milligrams, followed by 500 milligrams every 4 hours after the loading dose. Some of the signs of Pronestil toxicity are prolongation of the PR interval, increase in the QRS duration, and occasionally decreased blood pressure, but in my experience, I have not seen these things to occur. On occasion, we will go to IV Pronestil, but this has been pretty much supplanted by IV lidocaine. The long-term side effects of Pronestil can be gynecomastia in males, and the one that I have seen most commonly is a lupus-like type of syndrome, giving the patients very severe arthritic symptoms, changes in their laboratory studies, and decrease of these symptoms when the Pronestil is discontinued. Occasionally, we will give the patient what I like to call a taste of quinidine. If the Pronestil is not effective, and usually a little bit of quinidine added to the Pronestil will be efficacious. Usually this is given in the preparation Quinaglute, 0.33 grams, Q 8 to 12 hours. We can monitor the quinidine, digitalis, and Pronestil levels if necessary.
Dr. Pesta will conclude his lecture after this final word from SK&F Company.
Doctor, the swelling in my ankles has gone down, but I don't have any energy at all.
Fatigue can stem from many causes, of course, but one of the recognized effects of diuretic therapy with thiazides is greatly increased excretion of potassium. Two methods of replenishing the supply of this vital electrolyte often meet strong patient resistance. For example, adding high potassium foods to the diet.
I used to like fruit, but right now I couldn't stand the sight of one more banana.
Picture, if you will, eating 3 bananas daily for just 1 week, or 6 oranges, or 3 cups of tomato juice. It really does take those outlandish quantities to provide the additional 50 milliequivalents of potassium required to replace the loss induced by thiazide therapy. Then there are the potassium supplements.
Is it really necessary for me to take that horrible liquid?
Unfortunately, they are saddled with a characteristic taste that is difficult to mask, and the newer tablet forms are expensive and inconvenient. There's a simple way to avoid potassium depletion in your patients. Direnium. That's triamterene from SK&F Co. You'll find that adding direnium to thiazides or furosemide not only enhances the diuretic action of these agents, but also effectively blocks or reduces the potassium drain. Of course, because direnium does conserve potassium, hyperkalemia can occur, though it is rare when urinary output is adequate. The BUN and serum potassium should be checked periodically, and any potassium supplements you may have been giving should be discontinued when direnium is given with thiazides or furosemide. You shouldn't reinstitute them either unless hypokalemia develops or dietary potassium intake is markedly impaired. Even then, the potassium level should be monitored closely. Please consult your PDR or the prescribing booklet accompanying this tape for contraindications, other warnings, precautions, and adverse reactions.
A word about the tachyarrhythmias. These include paroxysmal atrial tachycardia, paroxysmal junctional tachycardia, atrial fibrillation, atrial flutter, and ventricular tachycardia. Exclusive of ventricular tachycardia, our first mechanisms to convert this rhythm is the use of the mechanical means. This includes carotid sinus massage, and don't forget this is a massage. This is the performance of the Valsalva maneuver. And as a pearl, if you have a patient that is uncooperative, does not understand what you are doing, and asking them to do the Valsalva maneuver, you may effectively perform the Valsalva maneuver by placing your hand on the patient's abdomen, pushing down, and have the patient push out against you, thereby performing his own Valsalva maneuver. The Mueller maneuver is the forced inspiration against a closed glottis. This is difficult to do under the best of circumstances, and it is difficult to convince a patient to perform this maneuver. In my clinical years of practice, I have never converted a rhythm utilizing eyeball pressure, but yet we continue to read about this. I have not found it to be effective. However, if these mechanical means do not work, the treatment of choice of tachyarrhythmias in acute myocardial infarction is cardioversion. This must be carried out, and a very high incidence of conversion occurs with the cardioversion. A quick word also, much work has been present recently in the literature regarding bifascicular blocks, and it is our practice in patients with acute myocardial infarction who present with the bifascicular block that a pacemaker is placed temporarily to prevent the occurrence of the fatal dysrhythmias. We do not give these patients quinidine without covering them first with digitalis because of the fact that quinidine increases the conduction of the impulses across the AV node, and you can end up with a very rapid ventricular rate. We'll spend a moment now on discussing the complication of congestive heart failure and acute myocardial infarction. Thanks to our very young aggressive residents at Mount Clemens General Hospital, we have been able to utilize certain criterion for the patients with congestive heart failure. This has been the use of the Killip classification, and in the Journal of the American Osteopathic Association, this will be found. The use of the central venous pressure is important, and usually in the acute uncomplicated myocardial infarction, the CVP is elevated due to vasoconstriction and alteration in the blood volume. In congestive heart failure, this CVP elevation is markedly increased and is more of a tip-off as to the therapy that is indicated. The studies of left ventricular end diastolic pressure, pulmonary artery wedge pressure are beyond the scope of our discussion, but are helpful in the diagnosis of congestive heart failure. The congestive heart failure should be treated aggressively with the use of diuretics such as furosemide, ethacrinic acid, direnium, and the spironolactone products. Also, salt restriction, bed rest, and adequate sedation. Digitalis may be utilized, but it must be utilized with caution, since digitalis is a cardiac irritant and may predispose the patient to further cardiac arrhythmias. We will now speak about the most serious complication of myocardial infarction, and this is cardiogenic shock. As you are aware, cardiogenic shock, when it occurs, carries with it a greater than 90 to 95% mortality. Ideally, this should be monitored by the CVP and an intra-arterial line. As mentioned before, the patients are cyanotic, cold, clammy, and in extremis. This must be very vigorously treated with oxygen therapy and blood pressure elevation. We must ensure that an adequate blood volume is present, and this is where the CVP comes in handy. If the CVP is low, we then use plasma expanders in the form of dextran, and if dextran is not available, lactated ringers and any type of IV solution may be utilized in an emergency. If the CVP is normal or within the limits that you have set, then vasopressors are most effective. May I caution you to not use the vasopressors that have strictly alpha properties such as Vasoxil, because what this does is stimulates the periphery to vasoconstrict, does not stimulate the heart, and in essence makes the heart work harder. We have used in the past Levofed with the addition of Regitine for its alpha blocking effects. We have used Aramine, but currently the most effective drug in controlling blood pressure, especially in cardiogenic shock, is the use of dopamine. Dopamine is a precursor to norepinephrine. It has alpha and beta properties. It also causes vasodilatation of the renal and mesenteric vessels. The company that produces dopamine has a very effective and useful slide rule that is presented with the product, which can be used to determine the rate of administration, the concentration, and at which points various alpha and beta adrenergic stimuli occur. Recently, at our institution, Nipride has been used to reduce the ventricular afterload. This is utilized in the patient with cardiogenic shock in conjunction with dopamine. Dopamine stimulating the myocardium and the cardiac contractions, the Nipride causing vasodilatation, and as mentioned, decreasing the ventricular afterload. A few short words on the treatment of the post-infarctive patient. If you will refer to the American Osteopathic Association Journal, the METS, the METS system is there, and this will be helpful in equating the types of work and the stress on the heart.
And that concludes the AOA Audio Educational Service for January 1976. Our thanks to Dr. Carl Pesta of Mount Clemens, Michigan, and to our sponsor for this month, SK&F Company, Division of SmithKline Corporation. And thank you for listening, Doctor.